Last time, I introduced you to hemoglobin saturation curves. And I talked about how the change in the partial pressure of oxygen at the peripheral tissues is going to affect the amount of oxygen that is being offloaded at those tissues. The lower the partial pressure of oxygen at those tissues, the more oxygen we're going to offload. And it moves us from this 40 part per million, which is not indicated on this slide, but this 40 part per million range into a 20 part per million range, where we go from about 21% oxygen offloaded, and we move rather from this shallow part of the curve into a steep part of the curve, where a small change in partial pressure of oxygen is going to lead to a much more significant release of oxygen. That should make sense, okay, from a physiological standpoint. And this is all because of allosteria, right? The cooperativity in binding of subsequent oxygen molecules to each of the four subunits in hemoglobin. But then I introduced this slide and these early experiments that showed that pure hemoglobin, isolated from the blood, pure hemoglobin that has been purified, shows this saturation curve that's fairly similar to the saturation curve of hemoglobin entirely in the relaxed state. So there was the tight conformation and the relaxed conformation, and that affected that donut hole in the middle of the hemoglobin. Casting your mind back, is that ringing bells? You guys remember this? Okay. But this is not what we see in vivo, in the actual whole cell preps. Instead, we have this red curve here, where during exercise, we're unloading 66% of the oxygen that is being brought on board at the lungs, as opposed to 8% in pure hemoglobin. And the difference here is the presence of 2,3-bisphosphoglycerate, which is an intermediate in glycolysis. All right, it's one of the intermediate molecules in the breakdown of glucose. All right, three carbon fragment that is part of the breakdown of glucose. So, why? What's happening here? Well, let's go back to our T and R model for hemoglobin. Turns out that 2,3-bisphosphoglycerate is able to insert itself into the donut hole. It inserts itself into the donut hole. And in that donut hole, there are, on both of the beta subunits, there are three anionically charged amino acids, histidine 143, lysine 82, and histidine 2. So there's this pocket of negative charge, a -6 charge, right? And 2,3-BPG has I'm sorry, what did I say? Cationic, the positive charges. And 2,3-BPG has a -5 charge. So it's happy to insert itself into this pocket of positive charge. When it does that, it stabilizes, it preferentially stabilizes this, the T state, all right? And shifts the binding curve that we see in purified hemoglobin away from the R state a little bit towards that T state curve, which was over here. And we see the saturation curve and we get the saturation curve that's observed in vivo. All right. So what is interesting is that fetal hemoglobin has, rather than an alpha and a beta chain, it has an alpha and a gamma chain. So there are two alpha chains, and then instead of beta chains, we have gamma chains, a slight variant in fetal hemoglobin. And the difference is that the histidine 143 in the gamma is mutated to a serine, thus reducing the overall charge of this binding pocket from a +6 to a +4. All right? And slightly reducing the affinity of 2,3-BPG for that binding pocket. So the T state of fetal hemoglobin in the presence of 2,3-BPG is a little bit less stabilized. So the binding curve is going to shift towards the right or the left. What do you think, Matt?
Left.
To the left. Okay. And what is that? What's going to be the consequence of this? What do you think, Haley? Oh, Jacob.
It's going to take a greater difference in saturation to be able to offload the same amount of oxygen from the hemoglobin.
Okay, this is true. That doesn't sound like a good thing, though. What's the actual benefit here? The answer's in front of you there. What are you guys looking at?
We're going to pick up oxygen from the placenta, not from the lungs.
Yeah, it's going to take oxygen away from the mother's hemoglobin. All right, at the same, at a parity partial pressure of oxygen, the fetal hemoglobin is going to be higher on that saturation curve. Okay, it's going to be able to selectively take oxygen off of the maternal hemoglobin. So here's the fetal hemoglobin with the alpha and gamma, and the adult with the alpha and beta. And we have in blue the mother's curve, and then in red is the fetal curve. So at any given partial pressure of oxygen, oxygen is going to be coming off of the mother's, and there's going to be a net transfer to the fetal hemoglobin. All right? So maybe this is a good opportunity to take. I should have had a couple more slides in here. This is a pretty interesting story because the story of how a baby actually gets its oxygen, right? It's not breathing. Its lungs aren't operating. How does this actually work? And then, furthermore, what happens at birth? How do we shift from whatever is working here to what happens when the baby takes its first breath? So I'm going to go off slides for just a moment. Maybe I'll turn this so some of that gets recorded. Turn one of these on. There we go. Here's mom. We'll put mom over here. And mom has the supply to the placenta. So, let's see, I wish I had some red. It's okay. The white here is going to represent oxygenated blood. So, comes in to the baby's liver, actually. Comes into the baby's liver from the placenta and goes via, so this is oxygenated blood, goes via the inferior vena cava, normally carrying deoxygenated blood. Comes in to the heart via the right atrium, because it's the inferior vena cava. Then what normally would happen? What would normally happen? No. What would normally happen to blood that comes to the right atrium? Yeah. The right ventricle, then the lungs. However, in babies, that's only partially true. There is in the wall of the right atrium a hole called the Foramen Ovale. The Foramen Ovale. And what happens is this shunts blood from the right atrium to the right ventricle, or to the left atrium. Pardon me. To the left atrium. Where this oxygenated blood is going to get shipped to the rest of the periphery. Okay? So it's coming from here, goes down here to the left ventricle, and then goes to the periphery. However, some of the blood does go to the right ventricle. And that comes out through where? Where does blood that normally goes to the right ventricle go? To the lungs, right? It goes out the pulmonary trunk. So comes this way and goes this way. And then this left ventricle, I'm going to draw this is getting to be a complicated drawing here. I should have done a diagram on PowerPoint. But here's the aorta. To pick up this oxygenated blood that has been shunted through the right ventricle, there's another mechanism. It's a short circuit between the pulmonary trunk and the aorta. We call this the Ductus Arteriosus. So there's two mechanisms by which the fetus is sending blood to the aorta. First of all, through a shunt between the right atrium and the left atrium, and secondly, between a shunt between the pulmonary trunk and the aorta. You guys follow that? So as much of this oxygenated blood that's coming in and passing through the liver and coming up through the IVC is getting sent to the rest of the body. Now, why is the blood going, why do we have it this way? Why don't we just have it patched directly into the aorta? What do you think?
That's reflective of how our ancestors' hearts were set up when we were fish.
Okay.
So it's working with reverting back to a more primitive. Yeah.
I like the comparative anatomy attempt, but rationalize it for me physiologically.
Where you're not getting the adult circulation, where you're getting the transfer at the lungs. I don't know. Somebody else.
There's two reasons here. Does anyone else want to try their mind? Yeah.
It might be easier to change upon birth to close up those holes.
Certainly, the rest of my story here is going to talk about how we close those holes. But why close the holes? Why not just tap right into the aorta? Why send it through the liver and then go through all this rigmarole, and we can just tap right into that aorta. Anyone else? Just take a stab. Take a wild guess. Be brave. What do you think, Anna? You're brave. Yeah, so that's the first thing. There's two reasons I'm looking for it. First is pressure. The pressure on the aortic side is much higher, isn't it? It's much higher. And so this placenta, this is low pressure. It's already gone through a capillary bed to get into the uterine, right? This is a capillary bed right here. So this is low pressure blood coming through the umbilicus, no matter what. And it would have to be fighting against arterial pressure. So by going into the IVC, we avoid that. That's number one. That's a big one. What's number two? Why pass through the liver first? What do we do with our liver? We haven't gotten there yet, so you guys are, this is me kind of being unfair, but Killian, you're thinking hard, I can tell. Give me a guess.
Well, purify toxins and stuff like this?
It does purify toxins. Yes, absolutely. And that can be part of it. What else do we do with the liver? You were going to say something.
Yeah, I was going to say to get rid of toxins from maternal blood.
What else do we do with the liver? Yeah.
Does that have some role in like native immunity and stuff? Sort of kind of.
That's not the primary justification here. Yes, but yeah, what do you think?
We store glycogen there.
Yes, absolutely. We store glycogen there. Absolutely. And so the two main reservoirs of glycogen in the body are muscles and the liver, right? And the glycogen that's in the liver is what keeps your brain going. That's what gets broken down and utilized for neurons. And so sending the blood through the liver first is making sure that the liver gets first dibs on any glucose that it needs for glycogen reserves to keep that blood sugar stable for neuronal development. Okay, so 9 months have passed. 9 months have passed, and it's baby's birthday. Labor happens. Baby comes out of the birth canal and comes out into the broad light of day and suddenly takes its first breath. When this happens, so the blood pressure, you can imagine the blood pressure in a fetus on the pulmonary side is very low. It's very, very low. As soon as it takes a breath and inflates those lungs, that pressure jumps up. All right? It comes up to what it's going to be in a normal human being that's in the light of day. All right? When that happens, two things happen. First of all, that increased blood pressure here causes this flap, there's a little flap of skin, to close. As soon as that blood pressure on the pulmonary side goes up, the flap closes, and the foramen ovale is been shut, and within a few days, fibroblasts are going to grow over and seal that wall completely. And it's now going to become the fossa ovalis. Is there anybody who can tell me some pathology that's associated with that you've heard of before? Patent foramen ovale. A patent foramen ovale is one that does not fully close. It doesn't fully close. And the problem with this, there's a number of problems associated with this. The problem with the PFO is that it makes the likelihood of a pulmonary embolism, so like a air bubble or a clot or a fat globule that has been dislodged into the blood, something like that. It makes a pulmonary embolism an order of magnitude more likely. All right? So you are much more likely to have a pulmonary embolism with a PFO. A lot of people don't know they have PFOs. And in fact, I think, well, yeah, let me think about that. So 5%, 1 in 20. Yeah, chances are there probably isn't one in this classroom, but if the class was a little bit bigger, there would be a chance that somebody in this class would have a PFO. All right? Yeah.
So what closed on the
So we're going to get to the Ductus Arteriosus in a moment.
what was
The Foramen Ovale, the hole between the right
okay.
atrium and the left atrium. You guys are at a disadvantage because you don't have the anatomy lab with me. But in the anatomy lab, we dissect the heart and you get to see it. Feel it. It's a cool thing. If you get to medical school, you can look at it there. Anyways, so that's the Foramen Ovale, clinically significant. Then this shunt between the pulmonary trunk and the aorta, this Ductus Arteriosus, there is an extreme vasoconstriction that happens right there. It just clamps down really hard, and all of the smooth muscle cells eventually just deteriorate, and all that's left is a ligament, and we call that Ligamentum Arteriosus. Ligamentum Arteriosus. This is clinically significant. You guys were not born when Princess Diana died, but you've heard of her. Who knows how she died? She died in a car accident. Absolutely. Fleeing the paparazzi, right? She was in there with her lover, whatever his name was. They were zooming through some tunnel, and the chauffeur lost control and crashed, and she decelerated very rapidly. What happened to her actually is the heart anteriorly displaced in the mediastinum, that chest cavity where it lives, and this ligamentum arteriosum ripped away from the aorta and just ripped a hole in the aorta, and she bled to death internally quite quickly. So that is a thing. It's a problem. Yeah.
So does the Ductus Arteriosus turn into a ligament?
Absolutely. Yep. Yep, absolutely. And both of these things happen at that magical moment of birth, the first breath that the child has. All right? Soon as it inflates the lungs, brings air to those surfaces, the PFO, the foramen ovale shuts and the ligamentum arteriosus clamps off. All right? And then the infant has to turn over all of this hemoglobin that it has. It has to unload this stuff. It has to unload that. Throw your mind back to Monday when I talked about the recycling of red blood cells and hemoglobin. What was the heme, the porphyrin ring, what was that converted into in the liver? It became biliverdin and bilirubin, didn't it? So bilirubin and biliverdin are they become the bile salts. They are the pigments that lead to jaundice when you have liver damage. When you see a jaundiced person, they're bright yellow, and it's because of an increase in these bile salt pigments in the blood. And sometimes a baby will be a little bit jaundiced from this process of breaking down so much hemoglobin so rapidly. All right? Nothing to worry about. They're going to be fine. A little bit of vitamin D3 will help in that process, a little exposure to the sun. Yeah.
So when people talk about AAA, and I forget what the acronym is, but like aortic aneurysm or whatever, is that more likely to occur at that site? Is it like a point of weakness or not really?
I don't actually know the answer to that. So I'm not a physician, right, and I don't have any like clinical history that I can draw on. But all of the aortic aneurysms that I've run into were not there. They were somewhere in the abdomen, just like big, ballooning of the abdomen. I don't know whether or not that's a thing there or not. It may be. The only other thing the pathology I can give associated with that is there is a connective tissue disease called, it's not Marfan's. I'm blocking the name now, but I had met a man. It was in a former life when I was an artist, and this guy had hired me to make a piece of art for his boyfriend, and I did that, and then the piece broke, and he wanted me to fix it. Whatever. The guy who originally had commissioned the piece, he died in his sleep at night because he had this connective tissue disorder, and there was that same separation that Princess Di had there while he was sleeping. So I wish it's not a very good story. I can't remember the name of the disease, the specifics of it, but I don't have much else to tell you about the Ductus Arteriosus. There's some connective tissue disease that particularly targets that spot. Yeah.
And that vasoconstricts just instinctively?
Yeah, right. So it's part of the. I wish I could tell you what receptors are actually specifically engaged there, but it's going to be sympathetic stimulation that causes that contraction there, and I think it is also mediated by the oxytocin that the infant has in their bloodstream from the mother, whose own system is awash in the oxytocin. It's a good question. I should get the answer to that. But yeah, it's like a sympathetic and a endocrine reaction that causes the vasoconstriction right there. All right. Are there any other questions on that? Yeah.
What would be the immediate sign that this wasn't happening? Would the doctors have some kind of
You mean that the ductus arteriosus wasn't closing off? Well, so the foramen ovale, there's a flap of skin that is going to get pushed down over that hole because of the rise in the pressure in pulmonary circulation. So that's not even really biochemically mediated. That's a sort of a biomechanical phenomenon. It's a pretty foolproof system. Yeah.
I mean, it's not foolproof because when 20 people have the incomplete.
It doesn't entirely fuse. Yeah, it's a problem. The thing is, a PFO can be subclinical. It's actually subclinical for most people for most of their lives, unless you have a fully thorough cardiac exam. It's not going to show up. And the patency can be very small. Maybe there's just a tiny little hole. It can also be the source, when it's more significant, it can also be the source of a thrombus, right? So because there's going to be a lot of turbulence in the blood at that point, it can activate the clotting factors and lead to a thrombus right there. But for most people, it's fairly subclinical because the PFO itself is quite small. It's only, in the. So I said, about 5% of people have some form of patency, and then in that population, there's like a distribution of different types of pathology that's associated with it, and that's still only maybe like 15% or something like that. Yeah, so it's pretty high though, whatever those numbers are. I've talked about it before. I forget the numbers off the top of my head. Maybe next time I'll put them in here. But any other questions? It's an interesting topic. Okay, so more hemoglobin. Oh yeah, Sonia.
So the ligament that happens when the Ductus Arteriosus turns into the ligament, does that have any kind of purpose, or is it just to plug that hole?
It keeps the aorta and the pulmonary trunk sort of tacked down to one another, and I'm sure of it, although I'm not certain that anyone's done. Probably, I mean, cardiodynamics have been so thoroughly studied, but may actually lead to helping the biomechanical process of contraction in the heart by providing resistance or something like that. Yeah, I'm sure it plays into the biomechanics of contraction in the heart. Exactly how, I'm not prepared to tell you that. But some other things I could say about this that I maybe didn't talk about. Did I talk about the iliac bifurcation in the... yeah. So another kind of interesting thing about the aorta, so we talked about how it was elastic, but you'll remember that, or maybe you won't, maybe we didn't talk about it. We have this iliac bifurcation at the abdominal floor, right, at the pelvic interface there. And when you have a contraction of the heart, there is a heart rate that you can find that's sort of harmonically tuned to this length of the aorta, where there's the pressure wave that comes down, and then there's what's called a solitonic reflection that comes back. So, like, when you have a train car that, like, the engine comes in and there's the bop, 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 down the length of it. There's something that's called a soliton, or like those balls that executives have in their thing. There's a reflection that comes back the other way and helps to close that door and helps reestablish the proper is part of the afterload equation and helping to reset that cardiac cycle, so that length, there's like a heartbeat at which that length, the heart becomes more efficient because of the reflection off of that. As far as the ligamentum arteriosus, I can't tell you specifically how that's going to help, but I imagine it's providing resistance for the contraction of the heart. Yeah, maybe it's a question you can ask the cardiology. You should ask Dr. Michael Lacombe. He's the head of cardiology at Maine General, who is going to be running this party we've got then. Yeah, he's a perfect person to ask about that. All right, so let's get on to Christian Bohr, Niels Bohr's lesser known cousin. So this Bohr effect is the effect of pH on the saturation curve. So both pH and temperature are going to affect these curves. And this guy here, back in 1904, he was already establishing, able to do these very careful experiments, establishing this relationship. And in the next slide, I'll show the actual experiment. But what he found was that when you have oxygen release at the tissue, that's going to facilitate the pickup of H+. So hemoglobin can transport an H+ ion as well. It's an effector. And conversely, the pickup of, so an increase in hydrogen ion concentration or a decrease in pH is going to facilitate the release of oxygen. All right? And I could ask you to rationalize that now, but maybe I'll go to the next slide because it's easier if you see it here. So the experiment here was at pH 7.4. This is the upper end, you know, or like middling. This is middling pH, right? 7.4 is this is no carbon dioxide. pH 7.4 would be this red curve. Am I saying that right? Yeah. And that's giving us about this at exercise max. That's giving us 66% offloading. However, if we drive it more acidic, if we increase hydrogen ion concentration, we're going to, but still no carbon dioxide present, we are going to facilitate off-gassing or unloading of oxygen. So at this exercise limit of 20 torr of oxygen, it goes from 66 down to 77% of the oxygen is unloaded from the lungs. Now you may ask yourself, why am I putting no CO2 in here? It turns out that carbon dioxide is also an effector of hemoglobin. I alluded at the beginning of all this to the fact that hemoglobin is really complicated. There's a lot of effectors that can play into it all at once. And we show these two-dimensional saturation curves, but they're actually quite multidimensional if you consider the effects of all of the different effectors. And so now let's keep it at the same pH, right? So very acidic. This is, you would not be feeling good at this pH. In fact, you certainly would have already vomited and maybe have passed out at this pH. But this is what we're doing to identify the curve here. At this pH, we are now going to introduce 40 torr of carbon dioxide, just atmospheric pressure of carbon dioxide. All right, at atmospheric pressure carbon dioxide. And that brings us from 77 another 11%. Okay, so the presence of carbon dioxide, with increasing carbon dioxide, you're going to increase oxygen offloading. All right, so this makes sense as well. As the hemoglobin gets towards the peripheral tissues, where you have higher concentration of carbon dioxide, the hemoglobin is going to want to unload oxygen more, and as you dial carbon dioxide back, that effect is going to be less. All right? pH. As pH goes down, as you go into acidosis because you are exercising and building up lactic acid, for example. As pH goes down, as carbonic acid goes up, right? So as you acidify your peripheral tissues by the buildup of carbon dioxide, you're also going to be more likely to unload more oxygen. Does that make sense? The Bohr effect. Essentially the effect of hypercapnic tissue, tissue that's high in carbon dioxide, and thus high in hydrogen ion concentration, low in pH. You guys follow me? Is anyone in the woods? Okay. So, still avoiding the question of whether anyone is a smoker in this classroom. I used to teach in Texas down there, and Texas Texas A&M Corpus Christi is not Colby College. There were a lot of people on that campus that were did not make wise lifestyle choices, and there were plenty of smokers. When I would go in to give a test, there'd be a whole clutch of them out in front of the building before the test, just sucking down a cigarette as hard as they could in preparation for the hour and a half ordeal that I was about to subject them to. I would lecture for like 4 hours straight and just like smoke as hard as they could before. So not smart, because they're flooding their blood with carbon monoxide, which binds to the heme, and its binding constant is 200 times that of hemoglobin, oxyhemoglobin. So carbon monoxide binds to hemoglobin and does not come off. It does not come off. All right? It's a problem. You're effectively taking hemoglobin out of your operational pool. All right? So even though they think they're getting themselves ready for the test, they're actually doing the worst thing possible to prepare for that test. But right before going into an exam, they're preventing themselves from having their brain from having all the oxygen it's going to need to take that exam. So you can see here at different percentages of carbon monoxide saturation, what happens to the oxygen binding curve. And well before you get to 40%, you are like in here, you are already losing the game. And then if you get much higher, you will certainly die. Yeah?
So are smokers generally having a lower, relatively stable pool of functional hemoglobin, or is the turnover fast enough that right after they smoke it dips down and their body kind of recovers and they have another cigarette and then it goes back?
Yeah, it absolutely is going to dip down and recover. As to what the chronic effects on hemoglobin titer is, I don't actually know. That's a great question. Whether they have responded by having a higher ambient hemoglobin level or not, I don't know. I'm not sure. It's a great question. All right. Oh, yeah. One more, yeah.
So when the carbon monoxide binds to the hemoglobin, you say it doesn't come off. So it basically waits until it recycles.
It does come off. That was an overly generalized misstatement. It does come off, but the binding constant is 200 times that of oxygen, right? So for the half-life of oxygen coming off of a hemoglobin, the half-life of the carbon monoxide is 200 times that, right? It's going to be significantly slower to come off. All right, so here's a little bit of a summary slide. And this slide will hopefully help you put all of what I talked about into context. So decreased temperature, decreased pressure of carbon dioxide, decreased 2,3 bisphosphoglycerate or diphosphoglycerate, BP or DPG, increased pH. You can also think about that as decreased hydrogen ion concentration, if you like the arrows all going in the same direction, right? All of those are going to shift it towards the left, shift it towards the relaxed state of hemoglobin. And then just turn those arrows around, and it's shifting it towards the T state, all right? So a decreased affinity for oxygen. Let that class out early over there. I wanted to talk about, kind of diverted myself there, didn't I? Let's talk about this for a moment, though. So this is a summary of gas transport. We have the alveolar airspace. Oxygen diffuses across the alveolar membrane, and then binds to hemoglobin. Is picked up by the red blood cell and binds to hemoglobin. Transported by the cardiovascular system, where now we have a different partial pressure of oxygen, and we're down at anywhere from 40 to 20 torr, rather than 100 over here in terms of the oxygen. So this oxygen is going to dissociate itself from the hemoglobin and diffuse into those cells where it's going to be picked up and utilized. On the other hand, those cells are going to use that oxygen to combust carbon, right? The carbon that's found in sugars, in glucose. And that combusted carbon dioxide is going to diffuse out of the cells. It's going to get picked up by the red blood cells. And I'll say that the process by which we transfer carbon dioxide to the lungs is a little bit more complicated, actually. There's more branches. So first of all, certainly hemoglobin is going to pick up some of the carbon dioxide and transfer it, absolutely. Some of it is going to turn into carbonic acid and dissociate into carbonate and the hydrogen ion. Hemoglobin will pick up that hydrogen ion and transport that. All right, and then this carbonate gets shipped out of the cell in what's called the chloride shift. The chloride shift. So we have parity of charge by shifting one carbonate out, one chloride in. Goes through the blood, and we just do everything backwards. We do everything backwards. We offload the chloride of the lungs, import the carbonate, reform the carbon dioxide. Carbon dioxide comes off the hemoglobin as well, diffuses out into the surface of the lungs. Yeah, Jacob?
What's the hemoglobin affinity for carbon dioxide versus oxygen?
They're very similar. They're very similar. So class is essentially over. Let me see. Well, this is an interesting one. I'll talk about this and then we'll call it. You don't need to hear about lung cancer. You all know lung cancer and smoking is a thing, right? So we can skip that. It costs a lot of money. So depending on altitude, the partial pressure of oxygen changes. This is why elite runners will go up into mountains and train, because they are in a reduced oxygen atmosphere. They're in a reduced oxygen atmosphere, and because of that, their body makes more hemoglobin. So that when it's time for the big race, they come down, run the big race, and their ability to transport oxygen has transiently been increased because of them running at a higher altitude or a lower availability of oxygen. So you can see all this. The highest human civilization on Earth is right around here, around 4,800 meters. And Mount Everest, people do go up there. I'm sure it's quite inspiring. That may be the lack of oxygen as well for them at the top. So, all right, that's it. Were there any questions?